Let me, Mike, before getting started, let me just throw out just a few words. I've been away for a month now. I spent the last month in the country of Lebanon, mostly in Beirut, but outlying areas as well. I went there for several reasons, in part to reflect on the work we do here, in part to reflect on the work I'm doing specifically, leaving a job where I was fired for union organizing and trying to figure out a path forward, income issues, professional issues, political issues. But just to say that some people have picked this up. I know in the media, there's been some attention paid to Lebanon. As of 18 months ago, Lebanon was doing fairly well economically, even having absorbed 2 million refugees, mostly from Syria and Palestine. But over the last 18 months, the economy has taken a serious crash. It's fallen by more than 90%. Unemployment is now over 50%. Lebanon used to be, and Beirut specifically, was known as the Paris of the Middle East. It was one of the more extraordinarily well-developed, well-educated, resource-rich nations in the Middle East. Its history goes back many centuries. It's often thought of as part of a greater Syria, often thought of in terms of Palestine, Jordan, Lebanon, Syria as a sort of an Arab unified or pan-Arab sort of collective, if you will. But Lebanon has gone through some devastating times, including a year ago when a warehouse explosion occurred, dislocating 300,000 people, wiping out entire neighborhoods. More than 200 people died as a result. Thousands were hospitalized. The society is experiencing a brain drain. One of the reasons I just mention this is because in many ways, at least the way that I see it, is that what we're watching in Lebanon, Beirut in particular, is neoliberalism on steroids. It's a society that does not provide a basic safety net for its citizens. And it in many ways looks like a canary in the mine cave or in the mine shaft. For where the direction that the United States is headed. And I think there are some real lessons that we can learn about the problems that they're experiencing there. And I plan on writing some things up on that, but I just wanted to share that very briefly with you. It was an extraordinary time. I made a point of walking more than 10,000 steps a day. Walking the streets, I walked through several refugee camps. I went to the mountains, I went to the ocean, I walked the streets. I learned some basic Arabic from a Syrian refugee. And in any case, they don't have universal health care. One possible employment route for me would be at the American University of Beirut. They actually have their own hospital. There's the American University of Beirut, one of a number of American universities scattered about the Middle East. But in any case, I just wanted to quickly share that I'll be putting together some thoughts on my experiences there and how we can relate them to the work that we're doing here, not only on health care justice, but also the larger question of universal transformative justice, of which I think we really need to be leaders. So thank you all for indulging me being away for a month. I think it was important reflection time, and I still have a lot more thinking and reflecting to do. So thank you. Mike?
Yeah, so I guess either Peter or Catherine, you want to go ahead?
It looks like Bill has his hand up. I don't know if that's from before, Bill.
Okay, California. Plenty of drama here, unlike Virginia, I guess, or rather Minnesota, but also a lot happening. I guess I don't know how up to date people are about the situation in California. The CNA introduced through Ash Kalra, an assembly person from the San Jose area, they introduced AB 1400 early in the year. The bill didn't go anywhere, and Ash Kalra basically withdrew it as a one-year bill and basically made it into a two-year bill, which means it'll come up again, hopefully in January of next year. He was smart enough to do it because if it had gone to committee, or if it had gotten committee hearings, it would have been killed. There simply was not enough support for it at that point. It's actually, the bill was drafted by Carmen Comsty of the Nurses Union, and it represents, I think, most of us agree, a big step over previous bills in California in that it closes the loophole which exempts HMOs, and most particularly Kaiser, from the ban on private insurance. This is critical, obviously, if we're going to have a universal risk pool in the state single payer plan. We have to be able to include people who are now enrolled in Kaiser, and there are about 8 million of them. It's huge in California. So it's a more ambitious bill. I think it's a stronger bill, but it also poses a lot of difficult organizing questions. The organized labor in California has longstanding ties to Kaiser. It was instrumental in developing the Kaiser model way back in World War II. A lot of union members are enrolled in it and feel they get pretty good care there, very good care there. In fact, Dr. Bill actually, worked in Kaiser for 30 years and can probably enlighten you a lot more than I can about how it works and why. But there's been a debate, I think, in OPS about provider compensation. Kaiser, I guess, uses a kind of a modified capitation system to pay its salaried physicians and providers. I think the question of provider compensation is probably less important than the question about whether we're going to incorporate Kaiser's 8 million people into our risk pool. And that's the real reason, I think, why we need to get this in. Now, there's a parallel track going on in terms of legislation. The legislature, when after the previous bill, SB 562, tanked, was basically killed by the Assembly Speaker to cover our then Governor Jerry Brown's butt. He didn't want to have to veto it, and he would have done it. But the current governor, Gavin Newsom, ran on a promise to promote state single payer legislation. He hasn't done a hell of a lot about it. But one thing that did happen was the legislature passed a bill creating a commission to study a unified financing of healthcare. That's, including single payer, not single payer, but this including single payer. So, make of that what you will. Governor Newsom appointed the majority of the commissioners, and I think really only 4 of them, I think, are strong, solid single payer supporters. One of them, fortunately, is Carmen Comsty. Also includes Bill Shao, the Harvard professor who designed Taiwan's single payer system, and the policy expert for the State Labor Federation, and and then a doctor named Rupert Maria from UCSF, University of California Medical Center, who's been really strong. She's raised the issue of COVID-19 and its impact on communities of color in particular in the meetings over and over again. The rest of the commission, they're all over the map, but I think it's significant that probably our biggest adversary on the commission is an ex officio member. He's the chair of the Senate Healthcare Committee. His name is Richard Pan, and excuse my French, but he's a perfect shit. Bill Shao actually gave a very interesting presentation on Taiwan at not their last meeting, but the previous one. Richard Pan chimed in and said he knew more than Bill Shao about Taiwan's healthcare system because his in-laws live there. He said all the Taiwan doctors can't wait to come to the U.S. and get away from their horrible system there and so on. I mean, this is the kind of stuff he raises at every meeting, and I think it makes me it's pretty much a foregone conclusion that any bill that got referred to his committee, he would do his best to kill. He did agree to hearings on SB 562. He did so very reluctantly. Anyway, so assuming that if AB 1400 doesn't get traction, the alternative strategy would be to try to get the commission, which is due to issue a final report at the end of the year, or rather early next year, to incorporate as much of the language of AB 1400 into its report. I should say, there's some debate about whether, the commission is just a hoax and it's there to mislead us, or whether it's an arena of struggle that we have to participate in and try to push as far as we can. Initially, the governor's representative on the commission, the guy who pretty much sets his agenda, is Dr. Mark Ghali, who's the the chief state health officer. Initially, what he did was he hired a consultant, who wrote a report which did a very good diagnosis of what's wrong with California's healthcare system, and then proceeded to suggest that the best solution was to get rid of fee-for-service. Again, we're sort of being diverted into a debate over physician compensation. And fee-for-service is clearly not the main reason why healthcare in the state is so expensive. I think everybody agrees on that. Ghali apparently is not that knowledgeable about single payer. He's presumably learning. And he's had his hands full dealing with the pandemic the last 18 months. A couple of meetings ago, a lot of the commission members kind of revolted against the way he was running the meetings. They said, look, you asked us to sit on this thing. You ought to be using our expertise some more and letting us talk to each other instead of just having us listen to a consultant and then say yeah or nine. So the last couple of meetings have been a lot more interesting. The discussion's been a lot more fruitful. Whether that's going to actually be borne out in good results, I don't know. That remains to be seen. In terms of what's happening this month, I'm not sure where the nurses plan to go right now in terms of reviving AB 1400, but they are having a call on next Thursday, I believe. And I'll be listening to that and see what they say. Healthy California Now, the statewide coalition, is sponsoring. We had a big, when the state opened up on June 15th again, we had a rally on the Capitol steps. A lot of the warm bodies were provided by National Union of Health Workers and Unite Here, which sent 3 busloads up from the Bay Area. It was a good rally, and the governor apparently did write a kind of a mealy-mouthed letter to the Biden administration, sort of hinting at the need for waivers, but not really saying what we wanted him to say, which is that we need those federal waivers to implement single payer in California. And, you know, there was sort of a nice letter from Speaker Rendon, the guy who killed SB 562. How seriously to take it, I don't know. So what we're going to do on the 31st, which is the day after Medicare's anniversary, is we're having rallies and events around the state. There's a big one in LA, which promises to be a really, big event. Here in the Bay Area where I live, we're going to have a memorial at Lake Merritt for all the people who died during the pandemic, either of COVID or because they could not access needed care because of COVID. And combine that with an urging the governor to keep his promise. We want to keep the promise of Medicare, which is originally supposed to cover everybody and provide comprehensive coverage. And we want the governor to keep his promise to push for single payer. So I'll shut up now. I notice Lynn is on the line, and so is Dr. Bill. They may want to add something.
Well, thanks, Peter. I'm happy to jump in. That was a really excellent summary, and I'll just throw some more fuel into the flames because I think you were rather nice about the conflagration that's going on. Kind of the movement is trying to eat its own here in California at the moment, unfortunately. As some of you know, Pilar Shivo, who is just an absolutely stellar leader in the movement here in California. She actually was the lead organizer for the nurses back in our previous bill, SB 562. She's known statewide and has thrown her hat in the ring to run for the state assembly coming up. So we actually featured her in our most recent national town hall for PDA last week. And she's also stepped up to be the lead organizer for a statewide coalition. But the controversy at the moment is actually causing some to even kind of direct their frustration at her in particular, because within the movement, you have these 2 different camps that over this this HMO carve out concept in the current legislation. Actually, the current legislation, so there's disagreement amongst the leaders over how HMOs are dealt with in the legislation, and that's caused some groups within the movement, within the single payer movement, to not be able to endorse the current bill, AB 1400. Unfortunately, that needs to be worked out, I think, among those leaders. And some of the people who are frustrated at the moment are directing that frustration at people like Pilar, even, which I think is unfortunate. The last thing we want to do is make this personal. I think there are good substantive policy discussions that you can have, and even about messaging, for example, how much of our focus needs to be around the bill per se versus just raising awareness still about single payer. The bill's author, Ash Kalra, had suspended the process of moving it through the committee process, because he felt he did not have enough votes to get it through committee. So he turned it into a 2-year bill. And so how can we then, as supporters, get more support, or apply more pressure to the elected members of the legislature to do that? And so some people feel very strongly that it needs to be focused on the bill itself. Other people say no, there's problems in the bill. So So there is that, and unfortunately, there's right now it's really a heated battle that is causing folks to kind of eat their own, even kind of losing sight of the like the old advisory that we need to hang together, or they'll hang us all separately, in my opinion. So there's that. Just thought I would add that. And nonetheless, Pilar Shiho is just a phenomenal candidate for our state assembly, and is worthy of support from everyone.
Lynn, go ahead, Lynn.
Okay, I've got quite a few comments here. You do not apply for a waiver until you have a statute. The CalCare handouts clearly talk about that. So to approach Newsom ahead of time was sort of a waste of time by us radicals in the movement. So the Single Payer Coalition in San Jose was questioning, why is HCN, which was created specifically to pass legislation in California, not supporting AB 1400? The reason AB 1400 has been delayed, 46 Democratic Assembly members are not on board. There's a whole flyer by Daybreak that shows you all their names. And that is because it does not have the financing in it. And I know Dr. Bill likes the idea of passing a policy bill. Well, that might have worked 15 years ago in California with SB 840. But nowadays, every single legislator needs to know how much their constituents are going to have to pay for the program. So that's what they're waiting for. And allegedly, Oshkara is working on a financing system. Not sure why they didn't have it to begin with, but and the commission, we radicals in the single payer movement, the commission is a joke, it's a sham. Now, Ghali has allowed single payer people to talk. Carmen Costi, Rupa Myra, Bill Shao. However, Bill Shao's bill in Vermont was not pure single payer. You don't approach for a waiver till you have a statute, because the Secretary of HHS at the national level is not going to feel comfortable releasing 71% of the funding, the federal dollars, before he sees how much California is going to come up with. Otherwise, California might rely on the feds for more money. So that's why there's this process, and there's a whole CMS handout that gives you every step in the way to get a waiver, and you have to have a statute.
Thank you very much. I'm Sam Metz. I'm a retired and rapidly aging anesthesiologist in Portland, Oregon. I'm one of 12 civilian members of the SB 770 Single Payer Task Force charged by the Oregon legislature to design a single payer healthcare system for Oregon and a funding mechanism for it. It sounds simple. By the way, the Oregon legislature did not obligate itself to even read our report, let alone act on it. So just let's keep that in mind. We have run into some challenges actually trying to put our money where our mouth is. Simple things like eligibility. How do we define who's eligible? That includes undocumented immigrants and the homeless, yet excludes people who live in other states but may visit Oregon. Benefits. By the way, I do ask that people keep questions to the end. Benefits such as if we were to provide hearing aids for everyone on Medicare, top of the line hearing aids, that would increase our budget by several $billion. How do we pay providers? How do we pay clinicians? How do we pay hospitals? How do we pay hospital systems? And of course, how do we create sufficient taxes to replace what people already spend in premiums, out-of-pocket payments, and self-funded plans? Coincidentally, in Oregon, the amount of money that we would need to collect in taxes is approximately equal to what the state already collects in taxes for its general fund, an approximate doubling of state taxes. This is not much different than what stopped the heart of Governor Peter Shumlin in Vermont when he realized it, and California's had a similar experience. For Oregon, that's $20 billion. That's more than a cigarette tax. And in fact, it would be not just the biggest single tax in Oregon history. We would need to apply taxes that have never been applied before in Oregon, such as sales taxes. You can imagine it's a lively discussion, even amongst single payer advocates. We have also run into something that's been alluded to in the California discussion. A state cannot create a universal care plan that pulls all of its spending on healthcare into a single plan without violating federal law. There are hundreds of streams from the federal government, especially in mental health care, that fund some aspect of healthcare. Trying to collect them all into one fund is daunting. Some of these programs have waivers that are difficult to get. Some of them have waivers that are impossible to get. Some of them don't have waivers. And some of them are out of touch with the federal government, such as self-funded plans, which would violate ERISA. Our committee has already sent an official letter to our U.S. State Senator Ron Wyden, asking if he might have slipped in the super waiver provision into the reconciliation bill. That did not happen, but it is my hope that the major output of our committee is to let the legislature know that we can't provide what they ask for without first getting a states' rights healthcare super waiver. Thank you for listening to the Oregon Report.
It's Catherine from Washington, Catherine Lewandowski.
Hey, Catherine.
Am I unmuted? Can you hear me? Okay. So I did, we recently did a town hall about a month ago or so. And so I pulled off some slides from that town hall and shared it with Mike. And I apologize that it was so late because I've been spending 2 hours this morning trying to get my computer unfrozen. But if Mike would like to share those, that would be awesome. My name's Catherine Lewandowski. I'm from Washington. I'm a registered nurse here, and I'm one of the board members of Whole Washington. And we filed an initiative this year to the legislature, I-1362. And so we need to collect 400,000 signatures by the end of the year. And if we do, this initiative will go to our legislatures in January, and they can pass it or they can vote it down. If they vote it down, it will then go to our citizens in November of 2022. And we thought long and hard about whether we should do that or not, but we really felt like in the wake of COVID, it would be immoral for us not to, even though we know it's going to be a very difficult hill to climb to get all those signatures. Anyway, so next slide, Mike. But why do we need I-1362? For decades, there have been universal healthcare bills introduced in our state legislature, and they have never even received a hearing in any of our healthcare committees. In 2019, the legislature finally passed the Universal Healthcare Advisory Work Group, and while our state Senate continued to refuse to have hearings on Senate Bill 5222, a predecessor to our I-1362, both in 2019 and 2020, in 2021, in the wake of COVID, our state Senate Healthcare Committee continued to refuse to have a hearing on Senate Bill 5204, which was a reintroduction of 5222. They did, though, pass Senate Bill 5399 and Senate Bill 5377. It's interesting to me how 5399 contains some of the same language from California's commission bill regarding a unified financing system. Anyway, 5399 creates a commission to look again at how best to implement a universal healthcare plan, and contrary to popular belief, Whole Washington did not testify against that bill, but rather other, and the details of why will come later. They also passed 5377, a bill that increased the subsidies to the insurance companies in order for them to sell our governor's public option plan on the ACA exchanges to poor people. It also forced any providers with more than 4 facilities in the state to accept that insurance, which previously very few had agreed to do because of the lower than low reimbursement rate. This one we did testify against because we do not feel there is any reason to continue to support this system of corporate welfare. We also shamelessly took the opportunity at these hearings to educate our elected reps and senators about the benefits of Senate Bill 5204. It was brilliant. Next slide, Mike. Here are some examples of language from 5399 that is most concerning to us. 5399 is a very different effort and initiative an initiative than our I-1362. And I-1362 and Senate Bill 5204 take the Universal Healthcare Advisory Work Group on their word that option A is the best model for moving forward. Option A was a single payer universal healthcare plan that covered everyone and saved the most money. Where 5399 contains language that gives the commission the ability to not implement a single payer system, that language only benefits the insurance industry. Here in section 1.1, 5399 states that while a unified healthcare financing system can provide universal coverage, increase access to care, decrease costs, and improve quality, implementing such a system in the state is dependent on foundational, legal, financial, and programmatic changes from the federal government. Also in 5399 in section 1.2, it states the commission will establish the preliminary infrastructure to create a universal healthcare system, including a unified financing system. Interesting that controls healthcare spending so that the system is affordable to the state, employers, and individuals once the necessary federal authorities have been realized. I-1362, however, is not dependent on the receiving of federal waivers in order to be implemented. I-1362 gives the commission the teeth they need to implement the intent of 5399 without waiting for the federal legislation. Next slide, Mike. So in section 7G of 5399, it states the commission will provide recommendations for the creation of a finance committee to develop a financially feasible model to implement universal healthcare coverage using state and federal funds. This work has already been completed. With all of the years of work that went into the development and refinement of our original I-1600 that led to Senate Bill 5222, where it was further refined in Senate Bill 5204 and is now fully embodied in I-1362. This section is a duplication of efforts already completed for the good of the people by the people. 5399 says in section 7C that in inventory of the key design elements of a universal healthcare system, including a unified financing system, there's that wording again, including but not limited to a single payer financing system. Our goal is to move as quickly as possible to a single payer financing system because that is how we achieve the most cost benefits. This language is weak and allows the legislature to maintain a multi-payer system. Such a system is a proven failure and only serves to benefit the health insurance industry in maintaining a stranglehold on our healthcare dollars. In section 7C8, 5399 states participant cost sharing, if appropriate. This language should absolutely not be included. Cost sharing measures are proven to discourage citizens from obtaining needed care. There should be no barriers to persons seeking care when they feel they need it. Ideas like this are introduced because legislators and health insurance executives feel that people need to have some skin in the game to encourage appropriate use of their insurance. But it has led to much more than that. They want your whole right leg and the ability to place your firstborn child into indentured servitude. Okay, I'm being facetious. To make a point, cost sharing measures are there only to increase profits to the insurance companies and discourage patients from seeking early care. Next slide, Mike. Section 9 of 5399 states that subject to sufficient existing agency authority, state agencies may implement specific elements of any report issued under this section. This section shall not be construed to authorize the commission to implement a universal healthcare system through a unified financing system until there is further action by the legislature and the governor. So 5399 has no power to implement any single payer system in Washington state without passing it through the legislature again. And a single payer system has been proven through all the work of the Universal Healthcare Advisory Work Group and others to save the most money and cover everyone, and was option A of the report to the legislature this year. I-1362 is the closest we can get to option A, with clear language on how best to transition completely to option A in a reasonable period of time. Our elected representatives understand that Senate Bill 5204 and I-1362 is a direct attack on the corporate entities who donate large dollars to their campaigns. Our elected representatives are trying to please their voters and also their corporate donors. That is like mixing oil and water. It can't be done, at least not for very long. So ultimately, next slide, slide 6. Anyway, 5399 has no ability to institute any recommendations without those recommendations again being passed. They have not been willing to provide us with this in the past, and they won't do it in the future unless we demand it. I-1362 is how we demand it through the enforceable power of our state constitution. They won't be able to ignore us any longer. There's more reasons on why we need it. I'm sure that you guys are all aware of the fiscal sustainability of why we are very impressed on what the whole Washington Healthcare Trust, if you want to go to slide 8, on how it affects our seniors on Medicare. So I'd like to cover that quickly. In short, it will be the most cost-effective and comprehensive supplemental plan available on the market for our seniors. And there's 3 system phases. Phase 1, when the whole Washington Health Trust passes, the board will apply to enter into a commonly used contract with CMS to become a Medicare Advantage plan. In this phase, when you enroll in the whole Washington Health Trust, Medicare will still fund your primary care, and the trust would act as a secondary or supplemental plan. In phase 2, when the whole Washington Health Trust is granted the Medicare Advantage plan contract, Both primary and supplemental care will be funded by the Whole Washington Health Trust. In this phase, you will no longer need to pay your Medicare premiums. In phase 3, when the state-based Universal Healthcare Act is passed, introduced by U.S. Representative Ro Khanna, federal funds will flow directly into the Whole Washington Health Trust. This will make the system much simpler behind the scenes, but will not impact the individual experience in this phase. Basically, all of the Medicare funding will flow directly into the trust, and the trust would administer all Medicare benefits. This is good for the trust, but it's also great for the Medicare recipients. Benefits are expanded to include medical, vision, dental, audiology, and prescriptions. Copays and deductibles are eliminated. Prescriptions are never more than $250 per person per year for those earning over 200% of the federal poverty level. The monthly premium is never more than $200 per person per month for those earning over 200% of the federal poverty level. There's no dual eligibility loophole that requires you to reduce your income. There's no provider networks. All participating providers within the state would be in network, and there's no shopping around for complicated plans. So, slide 9, the campaign is up and running. We are actively collecting signatures. We're actively fundraising. If you would like to go to our website, you can review the whole town hall and get all the information. And we would love to have, maybe you could donate your next mocha or latte to Whole Washington, or maybe your next overtime shift. And there's more, but I will end there. And if you have any questions, feel free.
Okay. And maybe you can put links in the chat box too, Catherine, just to reinforce. Thank you.
I can't.
You can't?
Washington.org. No, I've been fighting with my computer all morning. So you can go to Whole.org and check out all the information there.
Okay, and we could also send around an email to the listserv off of today's call with links to reports.
I can do that.
Okay, thanks a lot, Catherine. Mike, who's up next?
It's Caroline and then Bill Semple.
Okay, this is Caroline. I was going to give a brief update on Virginia. Mine will be brief.
Thank you.
But remarkably enough, Virginia did have proposed legislation the last 2 legislative sessions. The first time it was put forward by Delegate Samira from Herndon, Virginia, and it was a mandate about universal health care. It did not get any traction. So in the most recent legislative session, it was put forward as a study bill to, and it mandated a study of 2 different options, a publicly funded single payer and also a publicly funded single payer model, but administered by private entities. So, remarkably, it got some traction. It actually passed in the House. It died in the Senate because the committee did not take action on it on the Senate side. Our legislation in Virginia, it dies at the close of legislative session. So there's nothing currently pending. The beginning of the year, there will be a new legislative session, and we are very optimistic that something similar will be put forward for the next legislature.
Terrific. Thanks, Caroline, for your brief comments. Who's up? Is it Bill or Ann?
It's Bill Semple.
Okay, thanks, Mike and Chuck. Yeah, I think the excitement here in Colorado is around the legislation that in 2019, the legislature set up a task force to analyze 3 fundamental ways of paying for healthcare: how we're paying now, a universal multi-payer system, and a single payer universal system. And the task force that was created hired the Colorado School of Public Health to do the analysis. That the School of Public Health has submitted their analysis. It's not public yet, although their summary is, and obviously no surprise to any of us on this call, the only way to improve healthcare, cover everyone, and save money is a single payer. So we're looking to piggyback the final report that this task force will give to the legislature will be in September 1st. One of our board members on the Colorado Foundation for Universal Healthcare, T.R. Reed, who did Sick Around the World a number of years ago through PBS, he's going to be writing the draft for the task force anyways. It'll be interesting to see where I think they've got a political hot potato because it states very clearly, what we all know. And we know that it's a political fight. So we're looking to piggyback on that to develop the political support for the mass movement among all the other organizations that support social justice here in Colorado, to put the pressure on the legislators to have a referred measure in 2022 to our ballot. We all know what a big political lift that is, but that's what we're up to. Thanks.
Thanks, Bill. Ann?
Thank you. First, just I quickly like Ken Engelhardt to introduce himself because this is his first meeting, and then I'll go ahead and give you a really short story about what we're doing. Ken, are you on?
Yeah, thanks. Thanks, Ann.
Also on our board of Healthcare for All Minnesota.
Yeah, I'm Ken Engelhardt. Nice to meet you all. This is my first meeting. I don't have any kind of formal report to give. I think maybe Ann's more prepared for that, but just to tell you a little bit about myself, I am a retired internist. I practiced in the private sector for about 25 years, mostly at Marshfield Clinic in central Wisconsin. And then the last 10 years of my career is at the Minneapolis VA Medical Center. So I've seen both sides of medical practice, you know, the private and the public. So I'm on the board of Healthcare for All Minnesota, and I'm co-leading a coalition builders team here in Minnesota, along with Rose Roach, who's the executive director of Minnesota Nurses Association. I think most of you know Rose probably. And I know we're short on time, Ann, and you probably have more of a report to give, but I'm happy to chip in my 2 cents worth if you want to call on me again.
So I'll just say we're not even at the point of wrangling in the legislature because we have not yet gotten hearings. We've got 2 House bill and a Senate bill both reintroduced. We have a strong champion for single payer healthcare in Minnesota, Senator John Marty, who some of you may have heard of. We believe that his proposal is just excellent, and it lines up pretty closely with the federal bill on the House side as well. So we're pretty comfortable with the provisions, the plan. There's legislation written, but no hearings. We have a divided legislature here in Minnesota. The Republicans have a majority in the House, so the Senate. I'm sorry. So the House wasn't going to have any hearings because it wasn't going to get anywhere in the Senate. So we do have a new sponsor on the House side who is pretty enthusiastic, and we have some hope that he's going to add a little energy to that. I would say we're more at the point of organizing, really organizing and base building, and also doing what we haven't effectively done in the past, which is pull together a strong coalition of other organizations, progressive organizations, labor. So we might be a little bit behind New York, California, maybe some Colorado, some other Washington, Oregon, in really taking that step of pulling together those, some critical mass. We did some reorganizing of Healthcare for All Minnesota as well. We have an old, legacy mailing list. We pulled that into the new list, and starting to communicate with them. So, and we're just going to start some in-person organizing by tabling at the Pride Festival tomorrow, which is another group we want to work hard on bringing into this cause. The LGBTQI community. The legislature spent the session doing the usual dance of talking about incrementalism that isn't really going to help. The one thing that got a couple hearings was a state public option, which we just were neutral on because it's just not a good bill. They're not going to go anywhere. It didn't get anywhere in the Senate, so I think they had one hearing. And then Senator Marty did try for a cost study amendment and then HHS omnibus bill, and that was of course voted down on party lines. So I would say we're at the continuing to organize, build a base of support, and really strengthen a coalition in support of this. Our whole legislature is up again in 2022. So of course we don't officially endorse candidates, but everyone in the movement knows we've got to get a legislature friendly to this issue. The governor is not opposed, but he's a weak support for a single payer solution. I guess that's what I'd say where we are in Minnesota. Jen, would you agree?
I agree. And we have encouraging things going on in Minnesota, actually. Betty McCollum, our U.S. representative, recently signed on to co-sponsor HR 1976. And the coalition building is going really pretty well up to this point. We had our second meeting yesterday. We have 22 groups as part of the key allies. They vary from Latinx communities to business communities, farmers, labor unions, as Ann mentioned, and small business. Yep. And so that's encouraging too. So we just have to keep building the momentum. We realize it's going to take just a huge grassroots movement to make this happen because we're up against evil forces like United Health Group, which is located in Minnesota. And, they wanted to just recently deny emergency room payment for people needing to pay their emergency room bills. So things like that going on. But so far, so good. We're encouraged. It's going to take a lot of work, but yeah.
My last comment is that we have a situation similar to Kaiser in Minnesota. We have something called Health Partners, which is kind of a delivery system and a membership, insurance plan. So we have some big systems in Minnesota we are going to have to be going up against as well. Mayo, Health Partners, and so on. So we know we've got our work cut out for us. Yeah. Thanks.
Yeah, thanks so much, Ann and Ken. And Mike, I see your hand up. I just want to just pile on with the last comment you made here, which is what I focus on quite a bit, and that is to build our movement. We really have to be creative. We have to engage people. We have to build trust. We have to engage people who don't necessarily look like us or have our same background, experience, race, creed, color, all those issues. We've got to cross these barriers and build our movement as much as possible. So for anybody, I think I want to make that maybe the focus of our meeting next month, is to talk about where we are in terms of our organizing strategies, and just get an update on that in particular, since today was mostly focused on policy. We have our policy work group meeting next Friday for those who want to jump in on that group. And then a month from now, I think we can return to the question of strategy and organization building and what that potentially looks like. All right. Well, terrific. Everybody, thanks for coming together. It's a sweltering summer, I think just about everywhere. And thanks for your energy, and yeah, just stay connected, stay positive, keep building, keep thinking strategically, thinking big picture here, and connecting ourselves with other justice movements. That's, I think, really critically important for us.